Wonderful. And I promise that after you guys are done with me, you'll get some new voices and you don't have to hear me talk anymore. But today we have to every time we do the NCCR, we have to review our Halo procedures. So we have to go through kind of our high acuity, low occurrence procedures. And the reason why we do that is because a lot of times there's a lot of anxiety and pressure in those situations. And I want you guys to have the opportunity to think through all of these procedures and you will also get hands-on experience for these procedures during the practical session so that you feel more comfortable. And if you need to do these in the field, and I know some of your colleagues who are in the audience tonight have done some of these surgical airway and a whole lot more have done needle decompressions, but luckily no one in our department, and I hope that never changes, has ever done a needle crike. So that means that it's a very, very low occurrence procedure, and I'm sure that there's a lot of angst and concern about having to do that in real life. So let's get started. So we have our first case. We have the mom of a 5-year-old female calls 911 stating that her daughter is choking. BLS arrives, finds that she's tripoding in respiratory distress. You arrive as the ALS unit and find that she's in severe respiratory distress. She has a heart rate of 130. She has a blood pressure of 110/70. She has a respiratory rate of 46. And she has an SpO2 of 88% on a non-rebreather. So you start to do your initial assessment, getting her on the monitor, doing the necessary tasks to kind of tidy her up and get her out. When you notice that she is having some decreased mental status and you attempt to put an IV in, but you're unsuccessful. So because she is so sick, you decide to put in a tibial IO because now she is completely unresponsive. You push meds for MAI, you place the laryngoscope, and you see this. What is that?
A marble?
It's a marble. That is correct. Yes, it is exactly that. It is a marble. So something else that you could potentially see is a hard candy. Has a similar presentation. You can also see um, people can inhale teeth if they, especially little kids, if they do that. There's a number of different things that it could potentially be. This is showing how they are trying to remove said foreign body with what looks like, initially I thought it was a bougie, but it might actually be a Foley within a balloon that they're trying to expand to pull out. Now they're using some more advanced tools to, well, that's a, I don't think it's actually just simple McGill's, but they're able to get it out. So that was good. That was lucky for them because they have all the tools. Now they're doing a scope to make sure there's nothing else in there. But the initially with the marble, you see she's unresponsive. She's barely breathing. She has a complete airway obstruction, is what we're demonstrating here. And so then, you know, if you saw that, would you even attempt to pass a tube? Would you bail and say, we're going directly to a needle crike because this is a 4-year-old and we can't do a surgical airway, or kind of what would you guys do in that situation?
So right off the bat, I get the biggest tube that would fit because you have nothing to lose at this point. I'd attach it right to the suction tubing, put the marble right on the ball and try to pop it out that way and keep a good amount of suction.
That's a really
That's it.
interesting idea. Yeah. Yeah. That is, I'm not, in a kid that small, I'm not sure. Yeah, I think you would be thinking of attempting to do like an 8O tube, but I'm not sure you could get an 8O tube through those cords. So maybe a
Even if it's a five,
6O, maybe that's
even
a
if it's
yeah,
6-0,
yeah.
whatever it is,
hmm
but
hmm
get the suction going. Hopefully the saliva would create some sort of suction. You pop it out. And if you try to pull it back and you don't, the tube's already in, you just jam it in and get the tube in one of the Broncos.
Yeah, that's exactly right. So in general, what we tend to do if if there's particularly a hard foreign body is 100%. If you can, If you can grab it, at least in adults, foreign bodies are usually pieces of meat that people eat, that sort of stuff. In kids, it's more of the swallowed foreign body, like the tiny toy or marble or that sort of thing. So it's a little bit more difficult actually to remove them in kids in particular. So what I would do is I would attempt to pass a bougie in this case. I would attempt to pass a tube over the bougie and see if I can get the tube past the foreign body and just intubate there. If I can't, then I would do exactly what Tom was mentioning and try to jam that foreign body as far down as possible and try to right main stem it. Because yes, you are going to block off the right main stem bronchus, but at least you have something. At least you have a full oxygenation from one lung instead of two lungs. Because as you'll see, if you guys have, I think there's a couple of you who have not had the new presentation for the jet ventilators with the needle crikes. And so you'll see that even with the better flow with the jet ventilators, you're still getting way less flow than there would be if you're able to get any sort of ventilation with an endotracheal tube. So ideally, that is the best case scenario, but sometimes it's just not an option. So if yeah, so this is my demonstration, just showing that I would try and pass the bougie and do my best to get past the foreign body. But if you can't, you have to right main stem, essentially try to right main stem um, the object. In some cases, unfortunately, this is really hard. There have been some really bad cases of things like bubblegum um, or there's popcorn, but popcorn you can jam down in there. That's pretty good. But things, bubblegum marshmallows that are really squishy or that are really squishy and kind of hard to get through and are really hard to manipulate in that way. And you can't really push them and get through it. And so in some of those cases, it's really, really difficult to clear that airway. And in which case, you have to kind of go forward down your algorithm and say, all right, we've tried that. This was my best shot, but unfortunately, we have to go further. Now you're in this can't ventilate, can't oxygenate situation. And in this particular case, we have a foreign body aspiration, but you can have multiple different etiologies. So, edema with ACE inhibitors, which, believe it or not, we're actually seeing more kids being treated with ACE inhibitors because we're seeing more primary hypertension in younger patients with all of the dietary changes and all of the issues that are going on, similarly to higher rates of diabetes at younger ages. For infection, you can see epiglottitis. Luckily, since we came out with the Haemophilus influenza vaccine, bacterial epiglottitis rates have gone down substantially, but they do still happen occasionally. Croup is another big one where you get pretty profound irritation of the larynx and the vocal cords, and you get lots of narrowing in that area. Retropharyngeal abscesses are always a big issue where you have a kind of a peritonsillar abscess that kind of spreads down into the neck and creates a deep space infection that can compress the airway. Anaphylaxis is an oldie but goodie that we're pretty familiar with as causes of can't intubate, can't ventilate type of things. The other thing that did we mention it anywhere else? I'm sorry. I don't think we mentioned it here, but the ACE inhibitors can cause, now if we're going to be seeing them prescribed to people, we should be thinking about angioedema as well, which hopefully I have not seen angioedema from an ACE inhibitor in a pediatric patient yet. Hopefully I never will, but I can't guarantee that I won't. So the other thing we also should think about is facial trauma. So we'll talk about this a little bit in some future slides about surgical airways and surgically inevitable airways. There may be some surgically inevitable airways in pediatric patients as well. So in which case, if you're in this can't ventilate, can't oxygenate situation, you need to think about the needle. And in the past year, the recommendations for needle crike has been anyone less than 8, and over 8, we can do a surgical crike. Deputy, did I get that wrong? Was it 12 actually? It is. That's what I thought. I
Yeah,
I made
so
that,
it used to be 8,
yeah,
now it's
yeah, yeah.
12. They've raised it to 12.
Hmm. Thank you. Yes, that I do remember now. Sorry, guys, it's midnight here, so I'm a little sleepy. But why can't we do a regular surgical airway on a child? Why do we have to do this needle procedure? And the reality is that if you look at the two procedures, the surgical airway is way better at ventilating people. So why would we even want to consider this? So the reality is that the pediatric airway is a differently shaped airway. So the adult airway is nice and cylindrical. You have this big, thick larynx with the thyroid and cricoid membranes, or sorry, thyroid and cricoid cartilages. And you really do have this pretty strong cartilaginous cage where if you use where it's really hard to kind of go through and through the trachea and into the esophagus. In the pediatric airway, not so much. Their cartilage is not fully formed. They also have this more cylindrical, or sorry, this more cone shaped structure, or funnel shaped, where you have a big narrowing right at that cricoid ring, which is the smallest area of their airway. And so the saddest part is that the smallest part of their airway is right where you're aiming for, right? So it's really hard to find that membrane. It's really hard to get in there. And because they don't have a fully formed and thickened and strong cartilage around it, it's much more likely that you're going to cause damage if you're not in the right spot. So those are the main reasons why we just can't do that. So absolute contraindications, if you're able to do anything, if you have that MAI patient, you paralyze them and you've gotten to this point, but you're actually able to bag them, don't do a needle crike. It's way better to ventilate through a BLS airway than it is to ventilate through to oxygenate, because we're actually not even going to be able to ventilate these people to oxygenate through the needle. If so, I would say this is, to me, this is actually, this bottom one is more of a relative contraindication, because if if you think someone has damage to the larynx, cricoid cartilage, all of these areas, the other option is doing nothing, and that's just as bad, I would say. So in my opinion, even if you think that the patient might have a laryngeal rupture or a tracheal or laryngeal injury or tracheal rupture or a tracheal transection, and they're not able to be oxygenated and ventilated, I'm still probably going to try this because it's better than doing nothing. So that's, for me, that would be my kind of thought process. So relative contraindications, if you have really obvious anterior neck swelling and you really can't find anatomic anatomic markers or landmarks, it's going to be hard to do this procedure. But again, if the option is this patient is hypoxic and dies, you still have to try something. So that's why I would say it's a relative contraindication. If there's excess, just remember that this will likely be a bloody procedure, but as long as you're in as long as you're in the midline, the likelihood that you encounter any of the big vessels is very low. Okay, so let's talk about the procedure. So the good thing is that we've actually decreased the number of supplies that you need for this procedure since we added in the jet ventilator that is required by the state. So now all we need is an alcohol prep, is the needle that we're going to use, and the saline syringe that we're going to use to draw back to find bubbles to make sure that we're in the right spot. So positioning, you want to make sure, put your best foot forward, position the patient the way that you really want them to be positioned. Put yourself in that position to make it easier for you to do this. Prepare your equipment, identify your landmarks, clean the neck, and do the procedure. So identifying the landmarks, we're looking for what are the landmarks? What are we actually looking for? I know you guys know it.
Cricoid membrane.
Perfect. Yep. So we're looking for the cricothyroid membrane. So the cricoid membrane there is no cricoid membrane because it's just the cricoid cartilage. So we're looking for that membrane between the thyroid cartilage and the cricoid cartilage. And it's this tiny little membrane. And look at how tiny that is on a pediatric patient. And in some cases in neonates, it can be like tight, like less than a millimeter. So it's incredibly hard to find that to even attempt to do a surgical airway. So that's another reason why we just don't do it because it's so tiny. And then we're going to get ready to do the procedure. So what you're going to do is you're going to take your needle with the bevel up and insert it at 45 degrees caudally or towards the feet. And before you do that, you're going to push out probably 1 or 2 cc's of water so you have a little bit of working room to pull back on your syringe. And then as you're advancing, you're pulling back on your syringe. So the second that you get into the space, you'll see bubbles. And then what you're going to do is you're going to stabilize that needle where it is. And then you're going to advance the catheter, hub it to the skin, and then you're going to remove your needle. Remember, that is a really big needle. So be sure, and it doesn't retract. So please mind your sharps and don't stick anyone or yourself, please. Afterwards, you're going to attach the jet ventilator, which if you have not had the experience to use the jet ventilator, we will have that available for you at the practical session. And it's really easy to attach. It attaches to the oxygen supply just the way that your CPAP does. So it's something that you guys are very familiar with. And what you're going to do is you're going to compress the ventilation for 1 second, and then you're gonna leave it off for 4 seconds to allow for passive exhalation. This exhalation is going to come up and around the catheter, so it's going to be very minimal. The goal of this procedure is not to ventilate, and I repeat, not to ventilate. It is only to oxygenate. The expectation is that this patient will become very hypercarbic. And this is exactly why at the bottom here I mentioned that you really can only oxygenate for 15 minutes. So one thing I didn't really mention is before you kind of embark on this journey for the procedure, as you're setting things up, someone should be getting on to TAC 1 to tell dispatch, to tell whatever your destination hospital is, whether it's BMC, whether it's MGH, whether it's Children's, that this is happening and that you need their ENT colleagues there immediately when you arrive. And then once that needle is in, you're kind of married to that, unfortunately. So you got to be there. You got to be the one doing the ventilations and doing the oxygenation, that sort of thing. You can think about trach tape, but I really think that it's going to be best suited for you just got to hold it. Again, this is what the jet ventilator looks like. So if you guys have not had experience doing that, as a reminder, the way that we have this regulator here in the middle that allows us to change the PSIs. So we'll be starting at 20 and seeing if we can oxygenate and looking for chest rise. That's what you're looking for. And because there's no other way to really monitor it, you can't do end tidal, you can't do a lot of our other things that we do to monitor appropriate placement. So you do that for chest rise. If you don't get chest rise after 2 breaths, maybe, then I would up it to 30. Do that again if you're not getting chest rise. Then I want you to check for positioning. And then if you know that it's in the right spot, then you can start going up to 40 and 50, but we're never going above 50. So complications, asphyxia. Obviously, if you have someone in this dire straits, you can potentially expect that you will get some element of asphyxia. There's always a risk of aspiration anytime you are manipulating an airway. There's always a possibility for infection anytime you are putting anything through the skin. You can potentially, in this case, you could actually have an esophageal perforation because of the fact that you have that pretty soft cartilage. So you can actually go through and through, which is why it's really important to use that Seldinger technique to really only advance just as deep as you need to get bubbles. You can potentially get an expanding hematoma if you go off midline and end up damaging some vessels. You can also get some subcutaneous or mediastinal emphysema if you're not in the right spot or if it's become dislodged. So you got to really keep an eye on the fact, make sure that you're continuing, even though you may have gotten chest rise the first time, make sure that it didn't get dislodged when you went over one of those big bumps, and make sure that it's not now in the wrong spot. There's also a possibility if you go up, if you go in the wrong spot, you can damage the thyroid. My thought process is, look, the kid's alive. There's a surgeon that I'm sure can would love to repair that thyroid. So I wouldn't worry about that. And then there's always inadequate ventilation, hypoxia, and death, kind of similar to the asphyxia piece. It is always a risk. And like kind of the sibling to esophageal perforation, you have that posterior tracheal wall perforation as well. Any questions about needle prick before we move on? Okay. All right. So you have case number 2. BLS is pushing for an ALS intercept for a 34-year-old female who was a pedestrian struck. She was found unresponsive. She had agonal respirations, but with a weak radial pulse. They apply a pelvic binder with a sheet because this was before we had the T-pods. You arrive on scene to find the patient being bagged by BLS. She has a heart rate of 120, no spontaneous respirations. She has an O2 sat of 88% on 100% O2 being bagged, and her blood pressure is 90 over palp. You place a humeral IO. You do 1 gram of TXA and you initiate some fluids. You have no improvement in her respiratory drive. Her repeat blood pressure is still 90 over palp. Would you intubate her en route or wait until you get to the emergency department? What would you guys do in this case?
What's her heart rate?
120. What do you think?
What was your GCS? I forgot.
Her GCS is 3.
Yeah,
Intubate.
put her down.
Okay.
But it seems like
Um,
her shock index is pretty high too, though.
yes. Yep, exactly.
So might want to
So,
consider.
yes, Juan, what a great idea. So, you're right. Her shock index is, in my opinion, too high to go ahead with intubation. And I know there's always been this mantra of GCS less than 8 must intubate. The reality is that, and the biggest reason I think we have to intubate in this case is because she's so hypoxic despite being bagged. And so she's not able to be adequately oxygenated. And so she does need an airway. But she really should, if at all possible, she really should be resuscitated as quickly as possible in the meantime. But if she continues to become more hypoxic, then she's kind of pushing you in the direction of saying you have to intubate her, right? Um, Wonderful question. So she does have equal breath sounds bilaterally. She does not have any sign of pneumothorax at this time, but that's a wonderful question. So you decide to proceed with intubation because she is continuing to get more hypoxic. You push some etomidate and rocuronium. You attempt to place the laryngoscope and you meet significant resistance and trismus. And this is not, and you've confirmed that the humeral IO is in place. You confirmed that it's flushing well. So the meds got in, but she still has significant trismus. At what point do you say, all right, we're done here. This trismus is too much. Maybe she has a really bad jaw fracture that you just can't get around, right? And that's why she has such bad trismus. What point do you bail and say, we got to get an airway some other way? I mean, what would you guys do? Would you think about giving in, calling for orders for an extra dose of rock? Would you wait a little bit longer? What would you guys do in this case?
Nasal tube.
Yes, in the good old days.
Not being a
the
Weisenheimer.
Yeah, in the good old days, you could have done a nasotracheal intubation, but unfortunately, that's not an option for you now. So at what point?
Tom, it is.
Well,
And this
wait a
is
second.
actually
Why
so
isn't it? Why isn't it? Where is the protocol? I'm curious. Where is the protocol change that says it's not an option? If you have no other option, and this person is still breathing, and you've been
well,
trained in it.
they're not breathing because
Oh,
you
okay.
pushed accommodate and rock.
All right. I know this is Thurston. I didn't know if she was top breathing or not.
Yes, yeah. So she's now apneic. She no longer has a respiratory drive because you pushed meds, but you still have trismus and you can't open her mouth.
Plus, doesn't she have a head injury? Didn't you say she had head injury or no?
It's presumed because she was hit by a car, but
So
there's, you know,
let's not go sticking stuff up in the brain where you never know where it's
There's
going to
no
end up.
physical injuries to the head, Sue.
Oh,
And I'd still probably try before I cut the neck.
Yeah, that never stopped him before.
yeah, I mean, it's just one, it's not a skill
maybe if they were
that
breathing, but not if they're not breathing. If they're not breathing,
yeah, and it's
yeah,
also it's nowhere near as effective as
yeah.
it's just yeah, it's truly a blind intubation. So, um,
Are we saying
if
this is the can't intubate, can't ventilate scenario?
yes,
Okay, well then you can
yeah.
then you kind of force at that point, but if you can ventilate her,
Mhm.
then BLS the airway.
Correct. No, I 100% agree. Unfortunately, she's getting more hypoxic. She is really kind of filling up with blood and secretions, and you have to get a definitive airway to get past the injuries to her face. So this is one of those cases that I told you that we would talk about is I I've kind of harped on it for years of the fact that I hate that at times people call having to do a surgical airway a failed airway because there are some injuries that are surgically inevitable injuries. This one wasn't quite so obvious, but sometimes if you see really, really profound facial trauma and you have no idea landmarks and you're like, I have no idea what I'm looking at here. Up in the face, not in the neck. It's pretty likely that you're going to need to do a surgical airway in that case. If you get lucky and you end up being able to find the epiglottis and put a tube in, great. That's a great day at work. But there are some cases where you just look at it and you say, this person's probably going to need their neck cut. And that's not a failure. And so I think that if we can get away with that of just saying we're kind of working down our difficult airway algorithm and using it as a, a step down the pathway of trying to get an advanced airway, I think it's better language and kind of better reality for what we're doing for our patients here. Okay, so what are the steps here? So again, like our other kit, we have significantly reduced the pieces of equipment that we now need for our surgical airway. So now we need some alcohol swabs to prep the neck. We need a blade, and we need this awesome one-piece trach tube with a bougie inside it. So, and and here are the landmarks. It's the same landmarks that we were using for our prior for our prior procedure for the needle crikes. And but the nice thing is because it's in adults, the landmarks are a little bit bigger, a little bit easier to find. In men, the thyroid cartilage is much more pronounced, so it is usually more easily identifiable. It's a little harder to do in women, but if you have to, you kind of move the midline. Always starting at the midline is always helpful. So moving at the midline, tracking down until you start to feel something in the center, and then you come down until you feel this big triangular cartilage that's wide, and you can basically touch it on both sides and wiggle the larynx around. And then you keep going down until you find the cricothyroid membrane, which is right in between those two cartilages. And that's where you're looking for. All right. And then to perform the procedure, what you're going to do is you're going to do a vertical incision, and we're not doing horizontal incisions. We're not doing a cross hatching incision here. So we do a vertical incision here. And I like to tell people to give yourself a good working room. Give yourself a couple centimeters of an incision. Don't make a tiny incision because you have to get your finger in there. You have to get a bougie in there. You have to do a number. You have to put a number of things into that area. And so give yourself a little bit more working room. And then you're going to make that vertical incision. Once you're through the skin, you're going to use your finger to again find your landmark. So once you've then found the little divot, which marks the cricothyroid membrane, so blunt dissecting down with your finger, you make a horizontal, basically poking incision through the cricothyroid membrane. This is not a horizontal incision through the skin as well. It's just through the cricothyroid membrane. And then you're going to put your finger into the trachea and feel the rings. Not in this case, but in a different case, if you were, kind of like that first case, imagine that patient had a foreign body in their airway that you couldn't manipulate, but they were over the age of 12, so they were 14, and you went on to this procedure. If the patient were still spontaneously breathing, you could potentially, the second you open up that airway, you're going to see blood spurting as they're breathing. And so you're in that space. Then you're going to slide the bougie over your finger. And then you're going to advance the tube over the bougie, pull the bougie out, and then secure the trach tube there. The trach tubes come with trach tape that you can use to secure it. Obviously, inflate the balloon as well. Here's an example that I talked about of a patient who's still spontaneously breathing, who did in fact consent to have this recorded for educational purposes. And you can see there that this particular physician is kind of dissecting down with a scalpel. They're more familiar with how to dissect down with a scalpel than some other people may be. So I would not recommend doing that yourselves. I would blunt dissect down with your finger and just kind of move the tissue away. You can also see how bloody this procedure is.
So I got to ask, is he on CPAP? Why are they doing
Yes.
this? So why are they doing this in the first place?
He's on CPAP because he's not adequately ventilating. He's technically awake, but he is not adequately ventilating with the CPAP, and he has a very large mass. So he had a known mass that was in the area, and so basically knew that he was going to need this at some point, and he was not ventilated well enough for them to go up to the OR to do a trach, so they needed to do a surgical airway.
I mean, not to be pedantic, but I'm not sure you could make an argument the guy has capacity to consent to this. If he's so hypoxic, they're doing a trach or the surgical airway, but getting a little off topic.
Yeah, I don't know the details of exactly when and then this is afterwards that he did this procedure, and then this guy is very happy that he's still alive. I'm not sure the details of when exactly they consented him. I think they ultimately consented him again after to make sure that he was still okay with it. But it's a nice story. It's not a great, it doesn't look like an awesome video, but it is interesting to see that. So the reason why I show it is because there is a potential situation where you could where not necessarily you guys, because I can't really think of a situation where you guys would really have to do this in the field with a spontaneously breathing patient, but it has been done. It can be done. And you'll notice actually under this guy's fingers, you'll notice an area of like a white area. So that means that they also did inject some lidocaine there. So he is numbed. So he also doesn't feel it. But the interesting piece being once you get into the airway, because he's spontaneously breathing, you see the blood kind of spurting out, and it's very obvious that you're in the right space. So the reality is that some of these procedures and some of these surgical airways are going to be a lot harder than others. So if someone came in with this, I'd be very concerned about how am I going to find those landmarks? And this is a patient who had a procedure, a resection of either a thyroid or maybe some mass or something like that. And now he has a seroma and or a hematoma that's built up and is really obstructing all of his landmarks. If I had to do a surgical airway on this patient, I would hope to God I would never have to. But if I did, I would find what I thought to be the closest thing to midline and just make an incision through the skin and blunt dissect down until I found I found my landmarks. And again, I would not use my blade to dissect down. I would do it all with my finger just because you're going to cause less trauma if you do it that way. So these patients are also really difficult. This is someone who's had radiation from a head and neck cancer. And this is also someone who previously had a stoma. So a lot of times you'll get these really, really tight and contracted areas of skin that really obscure their landmarks and can make it really hard to feel anything, and can also make it really hard to kind of really get through that. They're really tough. So that can make it really difficult as well. This is a large mass. It would be a very bad day for me at work if I had to do a surgical airway on this patient. But again, what I would do is I would I would probably make an incision if I had to make an incision kind of around here where the land or kind of the margins of his mass are, and do the best that I can of trying to kind of get around it and find landmarks if I had to. Now, this is the one that we're probably most likely going to see in our practice here, is the patients with excess subcutaneous tissue in their neck. So you look at them and, maybe it's easy enough to be able to feel their landmarks underneath that, but maybe it's not. And so kind of similarly to what I talked about previously, is I would try to, extend their neck a little bit because it stretches out the subcutaneous tissue, and then find what I consider to be the closest to midline that I can find. So kind of find the middle of their nose, come down, track down here for midline, and make an incision, and then just kind of blunt dissect down to see if I can find landmarks. If you guys like mnemonics, this is the mnemonic. It's called SHORT. So anyone who's had prior surgery, anyone who has a hematoma, anyone with obesity or excess subcutaneous tissue, any prior radiation, any prior tumors. And the absolute contraindication to performing a surgical crike is anyone less than 12 years old. Relative contraindications are if you really can't find any landmarks, there are huge anatomical abnormalities, or if you think there's a tracheal transection and severe trauma and you think that doing this procedure would be futile, then you could potentially opt not to do it. I kind of similarly to what we discussed for the needle crike, I feel a little bit like it's better to do something than nothing in someone who is otherwise going to die. But that's also, you guys are your own clinicians. You can make those decisions for yourself. Any questions about surgical crike? And again, you will have opportunities at the practical session to do this. And I will mention also, I think all of you are aware of this, the state requires us to review and do hands-on training for you guys every 6 months. So we have created kind of a training schedule. So we're going to offer it. We offered it already in cycle 1, and we're going to offer it at both NCCRs, and we're going to offer it in, what is it going to be, cycle 6, Deputy?
muted here. For the surgical
For
crite,
the surgical airway station. Yeah.
we're still deciding when that will be, the 6-month period. Yeah, we haven't nailed that down yet.
Okay. But sometime in the fall. So
Yes, definitely.
spring, so it'll be spring and fall for NCCR, and then it'll be spring and fall for a regular site, for a regular in-service if you're not planning to come to NCCR. Okay, so case number 3, you are dispatched out to a person shot. You and the BLS arrive on scene at the same time. You find a 22-year-old man who's shot in the left chest. He's awake and alert, complaining of chest pain and difficulty breathing. He has an initial vital signs of 130. His blood pressure is 90 over palp. He has a respiratory rate of 30, and he has an O2 sat of 92% on room air. His initial exam reveals decreased breath sounds on the left, but he has no JVD or tracheal deviation, and his blood pressure is stable in the high 90s. Would you needle decompress this guy? Give me a thumbs up for no. Perfect. Okay. Perfect. No, not yet. Perfect. Okay. Yes. So now you package the patient, you get him in the truck, you notice that he's complaining of worsening shortness of breath, and you repeat his vitals. His heart rate is now 150. His blood pressure is 60 over palp. He has a respiratory rate of 40. His O2 sat has dropped to 85. Now it's time for the needle. So the reason why I make this distinction is that people can have pneumothoraces and be stable, right? What the needle decompression does is treating patients who are now unstable with their pneumothorax. So we don't want to needle someone who's stable with a pneumothorax. We want to wait to get to the hospital so they can put a chest tube in, which is definitive management. But once they become unstable, then you should needle them. But what are the landmarks? Where should you go? Where should you look to place your needle? So just a reminder to everyone, because I'm not sure how many people have done one of these recently, there are 2 landmarks. You have the midclavicular line at the second intercostal space. So just a reminder that the clavicle runs all the way to the sternum, all the way out to the shoulder. Now, this may be obviously, Dr. Weber, I know that, but what studies have shown is that people often estimate, kind of inappropriately identify the clavicle and report that it only kind of goes out to here. And then if that were midclavicular, then that would be located way too medially, and you could get yourself into trouble of kind of putting needles in the hilum and that sort of thing, which is not ideal. And so that's the one area, which I know from kind of querying you guys in the past, this tends to be what people go to first off in our department, because it's much easier to assess. It's much easier to kind of get access to the anterior aspect of the patient, and it's much easier to do kind of based on where you're sitting and whether you're at in the captain's chair or on the bench. The other option is doing the anterior axillary line at the fourth or fifth intercostal space, and this is the exact area where patients will get their chest tube if they need it. So if you go at this place in general, if you're not sure where the fourth or fifth intercostal space is, it's about at the nipple line for males, and it's about at the inframammary crease for a woman. So if a woman has large breasts, you may have to lift up her breast and look in the inframammary crease and kind of track that down. Remember that the ribs do this kind of uptrending motion. So you have to follow them kind of up. And so the fourth or fifth intercostal space will actually track itself way up into the armpit and much more superiorly than you think. And so just remember that it does kind of track up that way. Has anyone in the room or anyone in the audience change their first attempt from midclavicular to anterior axillary. No? Okay. That's fine. I think that if you're having good success with it and you don't have a patient who is has really a large amount of subcutaneous tissue on their chest, or it has really large pecs or something like that, you're probably okay to do the midclavicular line. But if you see someone that has a pretty hefty has a lot of tissue in that area, you may want to think about going in that anterior axillary line, because there was this study that I've been kind of mentioning over the years that it looked at cadavers to kind of see how successful people were at placing needle decompression or placing needles in both of those sites on various cadavers. And they found that the rate of misplacement was substantially lower in the anterior axillary line. And so you were much more likely to truly get into the pleural space if you went in the anterior axillary line. But I do understand the fact that it's hard to get to in the back of the truck. The patient is most likely to be restrained in, their arms may be restrained in the straps to keep them on the bed, and so it may be easier to get to the anterior axillary line. But if you're at all concerned, what you can always do is you can try you can try midclavicular, and if you don't have success with that, you don't get that rush of air, you're not sure if you're in, you can always try with that anterior axillary. And for me in the hospital, I do tend to do the anterior axillary because that's where I would go for the chest tube anyway. But I understand that I work most of my life in a different situation than you guys do. So you guys are your own clinicians. You can make your own decisions. But I'm just trying to give you the evidence that if you decided that you wanted to change it up, there's evidence to support you.
I mean, I did one last summer. Dave and I had a guy shot in the chest, in the right chest, and I said, "Well, why not? What the hell? I've done enough mid-clavicular, so I decided to go anterior axillary." But I think that's probably the last one I did. So I wouldn't say I've changed it. It's just that the opportunity presented itself, and I went for it. So
And did you find it just as easy, or what
I
was
mean, the
your?
guy, yeah, it was just as easy, for sure. The guy didn't ended up having a hemothorax and not a pneumothorax, but yeah, I mean, it was easy enough. He was a thin guy with good anatomy, so it was easy enough to sort of find my landmarks and just kind of popped it right in there.
Good, yeah. I mean, in thin people, it's kind of whatever you'd like to do, because the likelihood is that you're going to get into the space. So this is what we carry for our needle crikes. Our needle, not for our needle crikes, good Lord. This is what we carry for our needle decompressions. They are very, very large needles. I think they're about 4 inches long, if I remember correctly. And they are a 10 gauge needle. So it's a very large bore. So that's why it's really great for this particular indication. And there's always been a discussion of, okay, well, I have an 18 gauge, I have a 16 gauge. Can I just use that? And the reality is probably not. In an adult, I think it's very unlikely that an 18 gauge or a 16 gauge will be long enough to fully get into the pleural space. In a kid, the recommendation actually is to go down in in size, and depending on how large the kid is, they'll say, you should use a 16 gauge or you should use a 14 gauge, or whatever size. But for an adult, unfortunately, they're just not long enough. So complications with this, if you are incorrect in deciding that this patient has a tension pneumothorax, you can potentially cause a pneumothorax for this patient. Probably the most common thing are these last three. So not successfully decompressing it, meaning you didn't actually get into the pleural space. dislodgement, dysfunction, and kinking are going to be the most common things that you're going to see as complications here, because it is that flimsy little needle, especially if you are unable to fully hub the catheter to the skin. You're going to get a lot of kinking and moving of that. And so what people often find is that they have to place another needle, and you can do that either very close, kind of next to in the same space. But I would actually recommend, if you really think you have a tension pneumo and your first one didn't work, I would go to a different site and use a different site instead of putting a second in that area. All right, guys, we finished a little bit early. Any questions with any of the procedures that we went over today? You guys are ready. You guys are ready to put needles and use knives.
Okay, thank you very much, Dr. Weber. If nobody has questions for Dr. Weber and everybody feels comfortable that they can do needle crikes and surgical airways, we will see when practical comes. We are at 7:52. We have a guest lecturer presenting a physician from Mass General, I believe, doing a trauma lecture. So I would ask that everybody take a moment, get up, stretch, do what they need to do, come back. Please, if you are able, cameras on and attention. We have a tremendous amount of subject matter experts in our system, and we want to give them the respect that they richly deserve. They do this to make us better, gratis. So, all right, 7:52. We will see everybody back at 8 o'clock on the nose.
Thanks,
Thank you.
Dr. Weber. Enjoy your vacation.
Thank you
That's right.
guys. I'm
Enjoy the
coming
rest of your
back
vacation,
tomorrow.
Dr.
Oh,
We didn't break anything, so we're already ahead of the game.
I did not break anything. You're right. I've won vacation.
Lindsey Vaughn, you're not.
I am certainly not Lindsey Vaughn, but I'm also not as injured as she is.
Well, be safe.
Thank you.
Is
So that would be Deputy Schiller. She's in charge of our ALS training. I'm the NCCR recertification guy. We
Hi,
have about
Dr. Cohen.
hello, hello.
I hope you don't mind. We would like to record this so that those that couldn't join us tonight can benefit from your wisdom. Do you mind if we were
I don't mind at
seriously?
all. Hopefully,
Great. Excellent.
hopefully you'll find it wisdom.
I'm sure we will.
All right. Again, thanks. I hope everybody's back. Sue, did you make him a co-host? Can you do that? I can't do it from the phone.
I absolutely can do that. And
Thank you.
you have co-host capability and share capability if you want to share anything.
Sounds good. Whoa.
All right.
Share. Team. This is so much better than Teams. I hate Teams.
Oh, I agree.
Oh my God. Let's find. Okay, here we go. Share. Let's make this a presentation. Okay, does that look good to everybody?
Oh, yes,
Looks good.
perfect.
Perfect. Okay. So I'll go ahead and introduce myself and sort of a really appreciative of you guys letting us come in and give you a little education and hopefully you'll take away well, some of what we want, which is that to let you know we exist. We are a level one trauma center in Boston, as most of you know, and it's really important to us to make sure that all the EMS agencies around know that Mass General Trauma exists. We have, I think it's up to 10 pediatric surgeons now. Some of them work at some of the other locations as well, like Newton Wellesley. But they're all trauma surgeons. They're all really great surgeons, and I respect them, the whole group of them tremendously. We work with them super closely, and it's sort of really important for us to make sure that you guys are aware that when you're bringing a pediatric trauma patient to Mass General, that they're going to get exceptional care. I hope our interactions with you guys when you bring patients into us are good. If they're not, you should contact me. And if I'm the problem, contact Ali Raja, my boss. But like we really value the information that you provide. Sometimes it looks like we're distracted by whatever is going on, but we really should be giving you our full attention when you come in, especially for traumas. There's so little history and you guys have often have the only information about what happened to our patients. So if we're not giving you our undivided attention, let us know. We really try to get that patient transferred over the stretcher and then hear your story. Obviously, they're stressful situations, and especially when kids are sick or hurt. But it's really important for us to get the information from you in so hopefully a quiet space where you can convey that information. And if that's not going well, we certainly want to hear about it. Peter Matsiakos is the head of the Pediatric Trauma Surgery Service at MGH. I work very closely with him. I'm on the trauma committee. We try and do outreach to hospitals and to EMS agencies to try and make sure that people know that having two level one trauma centers in town is actually a really good thing. And we need to keep up our numbers so that we can stay in business from a trauma standpoint. And our numbers are up for this past year, which is good for our surgeons and our accreditations. Obviously, we hope that no kid ever gets injured, but trauma is a big part of what we do, and we want to make sure you all know that. I have nothing important to disclose. We're going to go through some trauma stuff and what makes kids different than adults, because there are a lot of differences, besides the fact that we all just get a little more nervous when a kid is injured, and it feels like the stakes are higher. But there are some unique injury patterns and unique things about kids that make their trauma care just different than adults. And if we have time, we can go into a little bit of concussions. This is really your time. So if you have questions, sometimes it's hard for me to monitor the chat, but please throw in the chat and someone will stop me with questions or just come off mute and ask the question directly in real time. Because probably if you have a question, probably six other people have the same question and are just less eager to interrupt. Um, Why do I care? I care because it's a huge burden on the system. It's a large part of what you guys do. It's a tremendous cost burden for society, the injuries and trauma care. Um, and specifically for pediatrics, there are many, many people that are just not comfortable dealing with sick and injured kids. EMS has to get all comers, just like the emergency room. But again, kids tend to make people nervous because there's just less of it. There's less pediatric trauma than there is adult trauma, and whenever there's less of it, or there's fewer repetitions for certain problems in kids, it makes people just be more worried. Also, kids like respond to trauma differently. They have different results of trauma. Um, and trauma is also changing. The what is causing the trauma has certainly changed over time. I think this is a really important couple graphs. I know they're a little bit dated, so I try to update them with more recent data. But basically, what it shows is that suicide rates and suicide attempts that goes along with rates are continuing to climb, even though trauma numbers have continued to decrease. And this is clear in the upper right. Sorry, the upper left graph is national data and Massachusetts data is in the lower right. And as you can see, even though overall trauma is down, suicide rates are certainly a driving force now of trauma in pediatrics. So trauma causes are changing. And we have to change our sort of preventative strategies as the cause of trauma changes. We talk a little bit about the anatomy of kids, and it makes why they're injured clear, right? There are smaller body mass. So the same amount of force that's being applied to a bigger person, if you apply that same force to a smaller person, the area that's injured absorbs more force. The force per unit of like per kilo is just more when you're smaller. Um, they're also developmentally immature. So from a psychosocial standpoint, their response to injury and stuff is just different than adults, and they're skeletally immature as well. So their skeletons are much more pliable, which leads to different kinds of injuries. So if you have you all know this, like if you're doing good CPR on an 80-year-old, like there's multiple rib fractures, right? If you're doing CPR right, ribs break. But that's totally different than on pediatrics. It's really hard to break a rib in a pediatric patient. So you don't get broken ribs, but you get the internal effect of that when the ribs get compressed. Instead of breaking, they just pass that force directly into the lung, and the lung becomes damaged or gets pulmonary contusions. So you may not have the fractures, but you may have more lung injury because the bones aren't absorbing all the force like they do in adults. That tells you that if you do have rib fractures or you do have skull fractures, it's really a pretty significant amount of force that's been applied. Kids are like pretty darn flexible. They fall out of buildings, they fall 10 or 20 feet and come sometimes walk away without any injury. You drop me out of a 10-foot building and I'm not walking away from anything. And one of the things that is challenging, especially in this time of year, although today was beautiful, so maybe not so much today, but as of a couple of days ago, the kids' body surface area is just so much bigger than adults, that their volume to ratio is the surface areas to volume ratio is just so high that they lose heat really quickly. And heat and cold is heat or the lack of heat being cold kids is really one of hidden enemies of trauma. Hypothermia causes coagulopathy, which causes problems with stopping bleeding. Also, ki little kids that are cold look awful, and so that this is one of those environmental factors that we can actually work on. We try to work on it in the emergency room and to varying degrees of success if we know you're coming in with a pediatric trauma patient, we try and close the door in the room and hike up the temperature in the room to make us uncomfortable. Because if we're comfortable, it's too cold. Basically, you should be sweating. If you're sweating, then it's probably the appropriate temperature in the room. But if you're not, it's probably too cold in that room. Plus, what do we do to these little kids? We immediately strip off all their clothes. So they get exposure. So they're exposed and they can be exposed for long periods of time unless someone's really paying attention to get warm blankets on them after they get disrobed. But cranking the environmental temperature, and you can do this in the rigs too. You can crank the temperature in the back of the rig to make sure that it's as warm as possible when you're transporting those pediatric trauma patients. So something that we can start before you get there, and we should certainly be continuing it when we get there if we know ahead of time that that kid's coming. This is one of those sort of hidden things that you don't necessarily have to think about so much in adults, and you certainly have to think about it more in kids. Their airways are different, and how you have to position them is different. Their heads are just huge relative to their bodies. And when you take a little kid, this is like, say, a 1 or 2 year old kid, and you lie them flat on the board, what happens? Well, their head tilts forward, and that crimps their airway. So that in order to get that airway nice and straight and flat, you got to get something under their shoulder blades. And this is especially true when intubating because it's very hard to intubate a crimped airway. So that having a shoulder roll or a folded, blanket folded in half and stuck under from the shoulders down is really important for getting appropriate positioning of your airway. Does that make sense? Um, their airway itself is different, and we talk about this a lot. Have most people done a pediatric intubation on a youngish patient? I can't see everyone's face, but like it's a little bit different. I think the stress level is a little higher because we don't do them as often, but they're just a little bit different. Why are they different? Well. It can be harder to see and to visualize the airway. In some ways, it's easier, right? They don't have like radiation damage to their jaw. They don't have arthritis of their jaw. They don't have dentures. There's some things that are simpler in pediatrics than in adults. But their tongues are relatively big. They have big soft tissue stuff like their tonsils in the back of their throat. Um, they have smaller orifices, smaller mouth aperture. So, people try and use oral airways and they try and flip them over and they cause minor trauma. And then there's bleeding, which makes it even more difficult to see. And then in general, their airway, their larynx is just more anterior encephalad. So it's it's just more anterior. So because of that, it can be difficult to one, see if you're not expecting that, and two, even if you see it, sometimes you can't get your tube there. Does anyone ever experience that sensation where you got a good view, but you just can't get your tube anterior enough to get it in through the airway? It's actually quite frustrating because you're like sitting there seeing the tube and too far down. So what do people do? So my general person, there's a billion different ways of setting up your tube, and everyone has a different way. The hockey stick, the curve, the angle of the tube going in. There are lots of different ways of doing it, and whatever you're comfortable, whatever works for you is perfectly fine. So because I know that airway is anterior, I tend to bend my tube a little bit. So I make sort of an angle to the bottom of my tube, which is all fine and dandy. And that usually gets me able to get anterior enough to get my tube in. But sometimes it actually makes it hard to pass the tube because if my tube is at an angle, so if my tube is, okay, I gotta get my fingers. So my tube is angled. What happens is I get into the trachea, but then the tube is angled too anterior and I keep banging into the trachea. So if my trachea is on the side, I'm banging into the wall. What I really need to do is get the tube to fall down flat. So there's a relatively simple way to do this. And has anyone ever used a hyperangulated blade, like a glide scope or anything like that? They have a rigid stylet that they use to get so anterior, which is great. But what happens is because it's so curved and rigid, once you get your tube into the trachea, the tube just bangs into the side of the trachea and doesn't advance. So what you have to do is you have to flip the stylet back while you advance the tube, because when you flip the stylet back, it lets the tube relax from the hyperangulated position and fall straight, and that allows you to pass it through the airway. So sometimes that's what you have to do when you're doing an ET tube in this age group, is that you go and intubate them. You have your angle of your tube. You're getting through the cords, but then you can't pass it. It just kind of bends. So what you do is you pull back a little bit on your stylet, let the tube relax, and they're all flexible because they're small and the mouths are hot, so that that flexible tube will then relax, and then you can usually pass it. So if you get into that situation where you just can't pass the tube, it looks like everything's fine, you're through the cords. Usually it's because the end of the tube is just banging into the side of the trachea, and you have to let that tube sort of relax so you can pass it, so that you lose that sort of angle you created to get to the right place. Does that make sense? Because that's probably the biggest challenge that I think people run into when trying to intubate a little kid. Either they're not expecting it to be as anterior enough, so they don't get a good view. But if they get a good view and they can't pass the tube, it's usually just because of the angle of your tube. So I say that a lot of different ways because I think it's an important part and an important problem that we can address. So the larynx is also funnel shaped, and that's, in the anatomy, it looks a little different. That's usually the problem. Problem is it does lead to a lot of secretion pooling. So for the really little kids, less than 1 year olds, I'm also using atropine for prior to intubation to decrease some of those secretions. Having suction in place while you're intubating often is necessary with really little kids because they have so much secretions. In trauma, obviously it can be blood, but even in intubating stuff like broncholytics, they just have a lot of secretions, and that can obstruct your view. The other problem is you get into the trachea, and what happens? Like, how many times, like, do I see the overzealous tube placement? So. You get really excited. I get really excited when I get my tube in, and the biggest thing is getting that tube in, securing that airway. And there's a tendency to be over enthusiastic and push the tube way far down, well into the right main stem bronchus. And you got to remember that the sweet spot for little kids is just much smaller. The whole trachea in infant, you're talking about 5 centimeters. So that your sweet spot where you want your tube is really small. So if you are aggressively pushing that tube down because you're so excited that it got in, you can easily pass into the right main stem bronchus. So I think I don't remember many formula calculations, but I think knowing the correct depth of the or expected depth of the tube will really help you and really helps me. And it's one of the first things I check when a patient comes in intubated. I just want to know where the tube is. So I find the simplest thing to remember is if someone's chosen the correct size tube, multiply that number times 3, and that's about the depth you should be at. So if a 4.0 tube should be at 12. If you're way far off, multiple centimeters difference than that number, you're probably either too short or too deep. So yes, auscultate, make sure it sounds equal. Look at chest rise. All those things are super important. but just to get a ballpark idea of where that you should end up, that is a number I remember and is super important. Airway problems continued. You got to pick the right size tube, right? It all goes awry if you pick the wrong size tube. So there's a formula. You can look up a list for age and size. There's a great app I have on my phone called PD-Stat, and I don't make any money from it. No, but it gives you like pull up an age or pull up a weight and just gives you everything you need to know for that patient. Gives you your tube size, gives you your blade size, it gives you everything you need to know in one place, which is super important because you don't want to be trying to remember a whole bunch of stuff when you're stressed and working. So having a quick reference, whatever quick reference you're going to use, having that readily available and have looked at it a couple of times so you know how to go, find the information you need. You don't want to be digging through for the first time when you have a sick patient in front of you. There are lots of ways to get that. You can use resuscitation tapes, that's fine. I do want to point out that the stylets that we use are longer than most of the tubes. So the risk is that you have the stylet poking out the end of the tube, and that can actually damage the trachea. So no matter what you're doing for your tube, just make sure that you bend over your stylet so that it can't advance past the end of the tube. For if you're using cuff tubes, which I almost always use nowadays, there's very little reason not to use a cuff tube. You're going to shoot for a half size smaller than that calculation above. So it would be age divided by 4 plus 3.5 if you're using a cuff tube. And obviously, the smaller the lumen, like 2.5s get ET tubes, which we use on, the neonatal population. They get clogged really easily. It just takes a mucus plug or a little kink to obstruct your tube. One of the problems with the small tubes is that they're so pliable, they're so small that they bend really easily, and they can just crimp off just from the tape that you do to secure them to the mouth. So what I usually do is um, I strengthen the tube that's outside the mouth by using a little bit of suction tubing, and I take a little length of suction tubing, cut it lengthwise so I can open it up, and then I just wrap it around the tube, and it gives the tube more structure. You don't usually need those in like fours and sort of like 5.5 or 5.5 or 6 because they're rigid enough. But those 2.5s, they just like flop over on you, and then they kink off. So I just use a little bit of suction tubing and put it outside the tube, and it just gives the tube more rigidity, so it doesn't bend right at the teeth and give you a whole bunch of resistance. Breathing rates, the kids breathe faster than adults. Their tidal volumes, again, usually their tidal volumes are 7 to 10 kilos, usually in the setting of intubating a kid. I'm usually shooting for more like that 6 per kilo, just because I want to prevent barrel trauma. So that it depends, you got to be able to move the chest. That's the most important thing. But you also don't want to cause pneumothorax. People, especially if you're using the big bags, like if you're using an adult-sized bag on a pediatric patient, like a pediatric neonate, it's really easy to overinflate them, right? Because they're only getting, if you weigh 3 kilos, how much tidal volume are you giving? What are you giving? You're giving 25 cc's. Right? Well, if you're using a 2-liter bag, that's going to be a problem because it's very hard to give such a small amount. So we all have small neonatal bags and pediatric bags, and just be cognizant of when you're excited about how much you're squeezing that bag and how much the chest is really expanding. In kids, the teaching is that the cardiac arrests usually are caused by respiratory arrest. That's usually the sequence. So that being really aware of the hypoxia because once they start getting hypoxic, then they start bradying really quickly. So that making sure you keep those oxygen up and you're sort of really aware of what's going on with their oxygen to prevent them from arresting. We really don't want to see this, right? This is the image we don't want to see when we show up in RED due to Barrett trauma. There are a lot of circulation problems, right? They're just different than the kids are just different than adults. So at 150 heart rate is totally normal for a newborn, or a couple day old, or even a couple month old kid. And you can have a heart rate of 200 and be totally normal in a screaming 2-year-old. So that knowing that what's normal is very different than what's normal for the older kids is important. And as I said, I don't remember many formulas. One of the formulas I actually use every day is the simple calculation for blood pressure. And once you're in the years of age, like it doesn't work for months, but for years of age, if you take their age and you times by 2 and add it to 70, that's sort of the lowest systolic blood pressure before you're considered hypotensive. So that's important for PALS. It's important for resuscitation. But it gives you an idea of what if the patient is really hypotensive, because nowadays a lot of services are carrying blood. There's more blood being given in the field, and we really want to make sure we're resuscitating appropriately. Blood's a limited resource. It does have some side effects to giving blood, especially if we're not giving O negative blood. So knowing what real hypotension is really important. And we'll talk about what kids do when they start losing blood. But in general, blood pressure begins to fall in kids about 30% of blood volume loss, which is like 20 to 25 milliliters per kilogram. And they don't really get frankly hypotensive until they lost just under half their blood volume. So why are they able to do that? And why does it seem like it's a cliff when it happens? It's because their ability to clamp down their vasculature is so good. They're so adept at increasing their systemic vascular resistance and clamping down on their vessels. They can maintain their blood pressure until much later than adults can. So it really seems like a cliff. And that's why we talk about, like, we don't want to get so far behind that they're hypotension. Once they're hypotension, we're really behind the 8 ball. We've sort of missed the clues. So we really want to certainly react before they're hypotensive. But it is challenging because kids can be tachycardic for lots of reasons besides hypotension or besides shock, right? They can be anxious, they can be nervous, they can be in pain, they can be screaming. There are a lot of reasons why they can be tachycardic, but it's very different to say, okay, it's a young kid, their heart rate's 170 because they're screaming. And it's another thing to have an obtunded kid who's the same age who's got a heart rate of 170, right? Those are totally different scenarios, even though the heart rate's the same. So when I look at a picture of blood pressure, this is sort of what it looks like. Heart rate starts to go up, but it takes a while until the blood pressure sort of drops. So they're really able to maintain. That's why everyone says it's like kids are like it's like falling off a cliff. They're fine, they're fine, and boom, they're no longer fine. So blood pressure is not what you want to use to judge shock. It's really all the other things like cap refill and perfusion and mental status. Those are really important to judging if patients are, pre-shock or shocky or getting to that point of shock, because you don't want them in frank hypovolemic shock because we've missed the boat and been watching them too long as opposed to treating them. So volume resuscitation. It's always a little bit of a challenge to know when to transfuse and when to not transfuse. There are obviously some cases that are very simple. There's blood everywhere, like patients hypotensive, they're pale and diaphoretic, and they need blood. and but there's also those kids that are screaming, they're tachycardic, um, and uh, and you're not really sure. This is one of the decisions that is tough to make in the field. It's easier to make when I'm in my emergency room and I have all the everything at my disposal, including ultrasound, and I can really strip down the whole patient and look for signs of trauma. And you got to remember that kids can hold trauma in places that you wouldn't expect. Like a kid can put a lot of their blood volume into their thigh. So a femur fracture can cause a large amount of bleeding, and sometimes in overweight people, it's really hard to notice that, and you can miss a pretty large amount of blood volume into the thigh. Um, in really little babies, they can actually lose a significant amount of blood volume into their head or their scalp. So it really can be tricky. Um, we talk about a massive transfusion protocol in trauma. Anyone that's requiring more than 40 mLs per kilo of blood. We do a 1-to-1 ratio of RBCs, FFP, and platelets. And when we activate this, it certainly gets everyone's attention because it's pretty rare that we have to do that. Do you guys give tranexamic acid, TXA? So it's great for adults, right? Like, I mean, the literature is actually really strong for the adult population. Um, uh, it's not as great for the pediatric population, unfortunately. The mortality numbers for adults really is way in the favor of giving. On the next slide, I'll show you about the pediatric data because it's just a little bit different. It's just not as robust.
Why is that? I mean, is it
Um,
that we don't study it as much, or there's a
it,
physiologic difference in there?
Right. Well, that is the question, and the answer is we don't know because it's not studied because it's not studied as much. Again, the number of pediatric patients is just way smaller, and there's physiologic differences. So coagulopathies are just different in kids and adults. The ability to clamp down, the ability to do things is just truly different physiologically, but between kids and adults. Because you're right. Why would it be different? Well, they just are. And I don't think we know the answer. And our pediatric trauma surgeons for trauma are a little bit dubious about using TXA for kids. But we use TXA for kids all the time in the OR, right? Like for neurosurgical patients, for other bleeding in the operating room. That's sort of very different than trauma. Why? I don't know the answer. It's a very good question. So it's not that TXA doesn't work in kids. It's just a question of whether it improves mortality or works in trauma patients. Uh, there's also this concept of permissive hypotension, which is really favored in adults, but really not so much for kids because of the perfusion of the brain problem, and their brains are still developing. But this is the data for kids in TXA, and sort of the best meta-analysis was in 2022, and TXA use was not associated with increase in survival in pediatric trauma patients. Um, they were able to find a subset of patients because they took a whole bunch of studies from multiple different venues, and there actually was some evidence of improvement in combat situations, so penetrating trauma from like war, for people less than 18. There did seem to be a benefit, but not for the routine trauma patients. But on the other side, they showed no difference in the odds of thromboembolic events. So they don't throw big clots. Because that's always the worry about giving something that causes people to clot. Are they going to have a stroke? Let me just close my door 1 second. the family's home. The downside is pretty low, right? Which makes people think, hey, well, let's just use it. And I can't say that's like wrong, even though our trauma surgeons don't believe that, and they don't advocate for liberal use of TXA. The risk is pretty low because it doesn't seem to increase your risk of clots that you don't want, like clots in your brain. There is probably a slight increase in risk of seizure with the use of it, but this is probably the best. There are some other studies that have come out since then that are more supportive of TXA. Um, Most of those studies have some sort of statistical and methodological flaws. So this one was actually pretty good in 2022. So I think the verdict's still out on TXA. I would, like last ditch effort, like someone's obviously bleeding out, you don't have blood, you got a ways to go. You show up in my ED, I'm not going to fault you for using it, because I think the downside is relatively low. I just don't think the upside is as high as it clearly is for adults. So. More important for you to probably get the patient to me than to give it. So I wouldn't want to delay getting that patient to me to get it into the patient. But enough said. It's one of those things that still hasn't been clearly borne out. It's used across the country in many different trauma programs and trauma settings. But I think the data is still unclear in the acute traumatic child. And also the doses are pretty there's large ranges of dosings that have been used in the literature, anything from 10 to 30 to just using the typical adult dose. Every place has their own protocols, and that's fine. And there's usually a bolus followed by some sort of continuous infusion. But I think you'll get different answers on this question from lots of different trauma surgeons. Okay, what do we get in the abdomen? Or why are kids' abdomens different? Uh, those damn kids, they cry. And when they cry, they entrain a whole bunch of air. And what that air does is make their stomach super big. And what does that push up on? Well, it pushes up on the lungs. So you don't usually get this in adults. Yeah, yes, you can decompress their stomach because they just ate a whole meal and stuff like that. So certainly decompression is both adults and kids. But it doesn't take that much of a full stomach to press up on the lungs and give you atelectasis and give you some compression. So thinking about decompressing the stomach is really important in pediatrics, especially the infants, like, 5 or 6 year old less so. But those little babies, that's really important to decompress the stomach. Also, they're more susceptible to injuries and solid organ injuries more than adults for a couple reasons. One is they don't have the abdominal musculature that adults have that can be protective. They also have really shallow pelvises, which makes their organs more exposed. Their ribs don't cover their spleen and their liver the same as it does in adults. So the solid organs and the bladder are less protected, so more likely to get injured. And then we get all these injuries from seatbelts not being in the right place, right? Where should your seatbelt be? Well, your seatbelt should be over your hip bones, and it should go across your chest. Unfortunately, when kids are not in the appropriate booster seats, that lap belt can be in the totally wrong place, which is usually across the abdomen, and the shoulder belt can be across the neck. Both of those things you can imagine be problematic if you got into a car accident. Uh, so duodenal hematomas is sort of our bane of our existence in pediatrics because they don't usually show up the first day, right? Like that hematoma develops over 24 hours and like a couple hours later after the trauma they start vomiting because that causes obstruction. So we have this really pretty low threshold for observing pediatric trauma patients for 24 hours to make sure that their abdomens are really fine. Why do we do that? Well, one is we don't want to scan every single patient, and we'll talk about that in a second. But two, these duodenal hematomas can initially be missed even on scans because they really haven't fully developed yet. Those lap band injuries, besides crunching on the intestines, also crunch on the spine. And the thoracolumbar spine gets compressed between the seatbelt and that hyperflexion as the patient is thrown forward causes these chance fractures. So chance fractures are problematic because they are often associated with abdominal viscous injuries also. So seatbelts in the wrong place really cause lots of problems in pediatric patients. Anytime you see that seatbelt sign, I'll show you a picture in just a slide or two. That seatbelt sign is one of those things that really does need cross-sectional imaging. So any seatbelt sign should be getting a CAT scan. Then the question, okay, so those organs get injured more. That's clear from their anatomy. But they go to the OR less. So we do fast exams on all traumas to look for free fluid. Well, free fluid in an adult gets you like a one-way ticket to the OR. Right? There's almost no one that gets a positive fast exam that's not going to the OR in the adult world. Well, that's just not true in the pediatric world. It is very rare for splenic injuries or for liver injuries to really need an operative procedure. Yes, if it's a grade 5 splenic lac and basically the spleen is exploded, and the patient's just like pouring blood into their belly, yes, they do need surgery. It's not that they never need surgery, but a lot of splenic and liver injuries just need observation. So a positive fast exam does not mean you need to go to the OR. If there's ongoing blood loss, if their hemoglobin keeps falling, yes, of course they're going to go to the OR to get packed and see if there's something that needs to be done. But we don't take out spleens like we used to. Kids need their spleens; they're an important part of the immune defense system. Removing spleens make them mildly immunocompromised. So it's not a benign treatment, and it's a big surgery. So a lot of times, even with positive blood in the peritoneal space, we'll still sit on them and not take them directly to the OR. This is the seatbelt sign I was talking about. That correlates with intestinal injury like duodenal hematomas, and any patient with a seatbelt sign gets a CAT scan. Fast exam, you can see blood just like you can see in adults. It just doesn't mean that a positive fast is going to go to the OR, and a negative fast it doesn't mean you're not going to go to the OR. So there's a little bit of discrepancy in the world of pediatric fasts about how important they really are, because it doesn't necessarily change your management. We still do them all, and it's good information for the surgeons to know. And sometimes it does spare us from getting a CAT scan. CAT scans super important in trauma. We do them all the time. We do them for a lot of reasons, but we also don't want to do them willy-nilly. We don't want to scan every single patient. We work really hard not to just pan scan every single trauma that comes in. Yes, if you're intubated, obtunded, severe mechanism of injury, like, are you going to get pan scanned? Of course. But a lot of the traumas that we see are like, yes, you have a little bit of belly pain, or yes, you have a head injury, but you have no other injuries, and you probably don't need a full pan scan. Why do we not just pan scan? We pan scan every adult. Why don't we just pan scan every kid? Anyone have any idea?
Radiation?
Yeah, radiation. And why? Like, I mean, 80-year-old gets the same amount of radiation. Hopefully not. And hopefully we use pediatric dosing. But if you give that same radiation, why do we care if it's a 2-year-old versus an 80-year-old?
The cells are still developing.
Yeah, so that's one really good reason, right? So a lot of their tissues are still developing. And what about cancer? Who's more likely to get cancer from that CAT scan? The 80-year-old or the 2-year-old?
The 2-year-old.
The 2-year-old, right? Like, because they have another 100 years to live, right? So there's a radiation risk for cancer is a cumulative lifelong risk. So if you got a CAT scan at 80 years old, the chance of that CAT scan causing you to get a solid organ cancer is minimal. You just don't have long enough to live for that. Now, if there's any 80-year-olds on the call, I apologize. But you just don't have long enough to live for my CT scan to have any effect. That's why everyone on the adult side of the emergency room gets scanned up the wazoo for almost anything, right? But when you're 2 years old, you have so long to live that extra radiation that we give you really can have an effect. And we don't know exactly what that effect is, truthfully. Um, uh, we don't know if it's a 1 in 5,000 risk or 1 in 10,000 risk. I'll show you a slide a little bit later, but like all the data comes from Hiroshima and dropping the bomb on Japan and trying to figure out how much radiation causes how much amount of cancer. So it's not an exact replica of medical radiation, but we know there is a risk. So there's nothing we do that doesn't have risk, but certainly giving someone a CAT scan, which can be more than a year's worth of radiation in one image. Um, Certainly doing that increases your risk to some extent. So we really try to limit CAT scans as much as possible. I'll go into that a little bit more in just a couple of slides. I want to talk about spines because spine injuries we talk about all the time, but they are really quite rare in pediatric. Why? Well, they're just friggin' flexible. Their bones just they really don't break. So that like I don't know if I've ever seen maybe one or two times in my 25 plus year career of a true traumatic spine injury in a kid less than one. Which is good because I have no way of putting a C collar on them either, right? I mean, like, yeah, C collars don't exist for these really little kids. Even a 5-year-old, ever try to put a C collar on a 5-year-old? It's just like miserable. Like it usually comes in and they're like it's up by their nose and and they're sitting there like heads all turned because they're just spinning inside the collar, right? So it's really hard. So it's good that they don't get injured very often. Obviously, severe mechanisms may need to be immobilized. But if the kid's sitting there doing like this, and before you get there and is like moving their head everywhere and is in no pain, the chance that they have a significant C-spine injury is pretty darn low. They sort of have clinically cleared themselves. That doesn't mean you shouldn't try to immobilize them and do your best. And if you're really concerned about the little kids, you just sandbag them. You get a couple liter bags of saline, you put them next to the head, you just tape that head down to whatever they're on. There are ways of immobilizing them, but a lot of times I see little kids come in with C collars that aren't nearly helping. In fact, they're usually hurting. They're usually uncomfortable, and the kids are in some weird position because the C collars don't fit. So be cognizant of the rarity of true C-spine injuries in really little kids. And we run into the problem is that also kids have these pseudo subluxations. So even when you get X-rays, which we don't get many X-rays anymore, we really get CAT scans because they're much better for fracture. But you have pseudo subluxation, especially C2 and C3, although C3 and C4 can be the same thing, where it looks like it's sublux, but it's really just a normal variant, which makes it really hard to interpret. And you get something called you see growth plates that get misinterpreted as fractures all the time. So there's a whole bunch of complicating things about it getting imaging in kids. And they also have something called sciora, which is spinal cord injury without radiologic abnormality, which means you get X-rays or CTs and you don't see anything wrong, and you only see it like on an MRI when you see ligamentous injury. So yes, CTs are much better than plain films for detecting this. These are plain films. You probably never see these anymore. I'm dating myself, but CTs are just way better if you're really concerned about cervical spine injuries. I don't get plain films anymore. Our radiologist would not clear a patient with just plain films. So if I'm really concerned about a bony injury, I get C-spine imaging, and if I'm really concerned about a ligamentous injury, I get an MRI. That's a bad one. You can see C2 and C3 that slip there. That's not a pseudo subluxation. That's a true subluxation. This is the CT. You can see at the top, there's a DENS view. Well, that X-ray view, you can imagine how much harder that is to see than this CT view, where you can just see that this is all blown out on both sides. So that is sort of like a axial load type injury. You can see it at the on the X-ray, but it's just so much clearer. Everything is so much clearer on CT scan. I think we just talked about this. Getting a little behind. Kids' heads are huge. And it's a big problem. That's why my kid had like a bruise in the middle of their forehead for like an entire year. Because where do kids fall? What do they hit? They hit their head. Their heads are a huge proportion of their body, and they're all top heavy, so they go thump, and land on their head. As we talked about, their brains are developing, so they need more blood flow. They are really susceptible to hypovolemia and to hypoxia. They're also really susceptible to hypocarbia, which causes decreased cerebral perfusion. And again, all our trauma care is to save one thing, it's to save the brain. Because if you save the body and you don't save the brain, I would argue that we haven't done our goal. We really want to save the brain and keep that kid neurologically normal. Their heads are huge. They can bleed into their heads, especially little babies can bleed a significant amount into their head, but they can also bleed into the space in the scalp. The subgaleal bleeds, certainly epidural bleeds can be big and they can have hypotension from it. The good thing in really little kids is we have the fontanelles. The fontanelles are sort of one window to the brain. That's why whenever you see a pediatrician, the first thing they do is they walk over and put their hands on their head. It's sort of something we were taught in medical school, and it's sort of the first thing we do on really little kids. And if that thing is really tense and bulging, you're really worried about badness in the head. If it's super sunken, I'm like, oh, that patient's really dehydrated. So it gives us a little clue to what's going on when we don't yet have imaging. Um, for the head in the Glasgow Coma Scale, there is a pediatric Glasgow Coma Scale that everyone should understand. The problem is like you can't if you use the adult Glasgow Coma Scale on kids that aren't verbal or nonverbal yet, you'll miss assess them. So that the verbal in a small pediatric patient would be the kid that's smiling and oriented to sounds and follows objects as opposed to talking because they just don't talk yet. So you have to convert your Glasgow Coma Scale to the right developmental age. Everyone's heard of, hopefully has heard of PCARN. PCARN study. This is like the study for head trauma. It's back in 2009, so it already goes back a long time. But this looked at more than 40,000 kids to try and figure out who does not need imaging, who is low risk and can just not get scanned. So it was looking for people that had low risk of a significant injury, and significant traumatic brain injury was death, neurosurgical intervention, intubation for greater than 24 hours, or remission for 2 nights to try and get the people that were really sick. And the results for less than 2-year-olds had these 5 factors: having a normal mental status, if they have a hematoma, only a frontal hematoma. I can't see your face in the way. Only loss of consciousness for more than 5 seconds, because there's all those kids that are like stunned for a second. Everyone's not sure if they lost consciousness. A non-severe mechanism, like you're not getting hit in the head with a baseball bat. You're not a fall more than 3 feet. You're not ejected from a car or a pedestrian struck. No palpable fracture, and they're acting normal to the parents. So if you have all those things, you're in the low risk group. For over 2-year-olds, it's pretty similar, but slightly different. But if you have none of those things, you're also in the low risk group. And what that really means is if you're in the low risk group, the chance of a clinically important traumatic brain injury is less than 0.02% for the young kids and less than 0.05% for the older kids. So that is as good as you're going to get. You're never going to get a study better than that, or a lower chance of a lower predictive rate than 0.02%. If you're not going to trust that, you're not going to trust anything. So how do you use this study? This is the study we use to rule out who does not need CT scans. Just because you have one of those five things doesn't mean you need a CT scan. But if you have none of those five factors, you do not need a CT scan. You do not need imaging, because you're in that low risk group, and the chance of you having a clinically important brain injury is incredibly low. And by using this in this study, we probably saved probably would have saved about a third of the patients from getting imaged. Um, is probably even more if we use those studies routinely, that this study routinely like we do now. It's even on like MD Calc, so that you can just pull it up on your phone and calculate what the risk of having an intracranial bleed. And that's why we just observe so many kids instead of imaging them based on this study. This is the CT scan stuff I was talking about. I just want to show this picture. This is old data, but it just shows you how much radiation that some of the scans that we do. So this is MGH versus the benchmark. This is old numbers. They have changed. But if you look at the 3.1, 3.1 is your sort of yearly radiation. Just from living in the world. So you can see that some of these imaging, a chest CT or especially abdominal pelvic CT, you can get 2 to 5 times your entire year's worth of radiation just from one of these tests. So it really is an issue that we try to avoid in kids. These are the things we don't want to avoid. We don't want to avoid the epidural on the left or the subdural on the right. And no trauma talk would be, no pediatric trauma talk would be complete without discussing abuse. Abuse is one of those things, if you don't think about it, you're going to miss it. We've all seen it. We probably have all missed it, to tell you the truth. There are some red flags that help us. And this is where you guys are incredibly critical parts of this history taking, because you're in the house. You know, you see stuff that no one else sees. And you take away from that visit that this impression of what the living situation is, and you need to convey that to us. If you see something, you have to tell us. If we're not listening, stop us and tell us. So if you see like untenable situation to live in, we need to know that, because otherwise we may not pursue a path that is correct. So the things we look for is we listen to your story, we take the story. If those stories are completely different, like parents says it happened at 4 o'clock in the afternoon, and then they said it happened at noon, and then they said they were with the uncle, and then they were with the grandmother, and like the story keeps changing. That makes us super concerned. And sometimes there's a really good reason why the story changed, because the person that's reporting the story wasn't there. But changing stories makes us nervous. Injuries that don't fit the history, like any bruising, in a less than ambulatory child, makes us nervous. There's the 10 faces P scale, which is it's a tool that we use for child abuse, and talks about the risk factors for child abuse. So injuries to inside the mouth or into oral injuries, injuries to the ears, injuries to the genitals, injuries that are in unusual locations like the back. Most bruises in kids are on their shins or on their arms, they're on their forehead. Those are all, really expected. But when they're in areas that don't make sense, or they're in ages of kids that shouldn't get any bruising, like 6-month-olds aren't walking. How are they getting to get bruised? That being said, my 5-month-old slammed his head into the table yesterday when I was holding him. So like it's not impossible, and we don't want to overcall stuff, because that leads to a lot of downstream consequences for the parents and family. But we got to be thinking about it, and we got to be aware of it, because if we're not, we're gonna miss it. So some of the things I wrote here are the things we worry about. And if I'm suspecting child abuse, then that whole radiation risk is sort of a moot point. I'm really going to scan that kid. I'm going to do a full skeletal survey. I'm going to get a CT scan of the head, because I can't miss a fracture. Because if I miss a fracture, I will not pursue down the right course of non-accidental trauma, which is so important. Because if I miss it today, I'll come back dead 2 weeks from now. So non-accidental trauma is super important, and your information is critical to us. We're all mandated reporters, and if you see something in the household that makes you nervous or you're concerned about, please make sure you convey it to us. There are lots of little tidbits on fractures that are obvious signs of trauma. I mean, you don't always review all X-rays, but these little buckle-handed fractures, these little slivers here, those are classic for a shaking episode. This, which is even harder to see, these are old rib fractures. There's actually like 5 of them on this X-ray. They're hard to see. Rib fractures are really hard to see. The only reason you can see it is because there's a big bulbous thing here where the bones are healing. And as we talked about earlier, it's really hard to break a kid's ribs. We're just at time. I just have like another couple minutes, if that's okay. Yeah, okay. Just a little few differences about the bone. Bones in kids, they have growth plates, right? Growth plates make our lives super difficult. So when I talk about injuries in adults, the weakest part of adult ankle or adult bones is going to be the tendons and the ligaments. The weakest part of a kid's bone is actually the growth plate. So if I have a kid that turned their ankle and they still have open growth plates, even if the x-rays don't show anything, if they're super tender over that growth plate, I assume there's a fracture through that growth plate. Because you don't necessarily have to see it, especially with this type 1 Salter Harris 1 fracture. It's an injury to the growth plate. It can be a slip like this shows, or it can just be a slight widening of that growth plate. But if you're tender over a growth plate after a traumatic injury, we kind of assume there's a fracture. The fracture line can go through the growth plate and then up to the diaphysis, or it can go down to the metaphysis. Once you get a higher Salter level, like Salter 3 and 4 and 5, these all run the risk of having long-term growth plate fusion or cessation of growth in that growth plate. Certainly with the level 5, which is sort of which is sort of a crush type injury, or level 4 where you go all the way through and then this bone starts to heal across the growth plate. Those all need to be fixed. These type 4s need to be fixed. Usually type 3s need to be fixed surgical. Type 5s is usually not very much you can do about them. And type 1s and 2s just usually need to be casted. So those growth plates make our lives more difficult. It makes it much more difficult for the radiologist to have to read them because knowing when growth plates close and what they look like makes pediatric radiologists really important. So this is one of those fractures. So this is a fracture through a growth plate that goes down into the joint. That's really unfortunate because that going down into the joint, if this if the two bones on both sides of the fracture are not perfectly aligned, that will lead to really bad long-term arthritis. Because the cartilage there'll be like a bump in the cartilage, or in the bone. So a lot of these kind of fractures that go into the growth plate need to get a CT scan so you can really see exactly what the anatomy shows, and you just can't get enough detail on an X-ray. And often they need to go to the OR to get immobilized as opposed to get pinned as opposed to just getting immobilized in the cast. Elbow fractures, this is like, trampoline parks and monkey bars. I mean, they keep me in business because that's what kids do, right? They do monkey bars and trampoline parks. And when you do that, you fall backwards. When you fall backwards, you put your arms down first, and when that force transmits directly to the elbow. So we see lots of these this time of year, springtime, and you get this a fusion on both sides of the elbow, and that's classic for a supracondylar fracture. So we see a lot of these, and usually from falling off the monkey bars and trampoline parks. And those fractures can be displaced, and if they're displaced, they got to go to the OR to get pinned. If not, they just get casted. but you really don't want to miss them because long term, if you miss them, they have all kinds of limitations in their ability to extend their arm. This is another clear example that shows this big effusion on both sides. You're allowed a little effusion on the front, but you're not allowed any effusion on the back. So in summary, the airway can be hard to visualize in kids. They are sometimes even when you can see them well, you can't get your tube to where they need to go because they're so anterior. And sometimes you need little tricks to manipulate the tube to get them there. The lungs are easily compromised, so they can get contusions really easily. They get pushed up on by a big amount of air in the gut, so they don't have the same functional residual capacity that adults do. So they get compressed, they get atelectasis, they get hypoxic really easy, and hypoxia leads to cardiac arrest. So really want to make sure that we're optimizing their lungs. Please don't wait for the blood pressure to drop before being worried about hypotension. You got to look at perfusion. You got to look at mental status. You got to look at heart rate and put that all together. It's just not one number in a kid that you're going to use. Because if you wait for the hypotensive, you're way behind the eight ball, and the mortality dramatically increases. We do consider radiation risks extensively in the decisions about who we radiate and who we don't radiate, and when we do that. So don't if you're picking up someone, don't tell them they're going to get a CAT scan. Let us make that decision. Because actually, a lot of the kinds I'm getting a head imaging, I can avoid a CAT scan in my ED and get an MRI, unless there's like a million strokes in line for that MRI. So sometimes I can avoid CAT scans altogether, even in patients that I need to get brain imaging. Cooperman study or the PCARN study that we talked about is really the gold standard for decisions about who needs to image and who doesn't. And please always consider abuse. Please look around the place when you show up, and you please convey that information that you get back to us in the emergency room because we just don't have your insight. And I think that's it. We definitely don't have time to go into concussions. I'm happy to come back some other time and do it, but I think I think I've talked enough to you guys. Questions? Anything in the chat I should answer before?
I see a few thank yous there, Dr. Cohen. I appreciate it.
Oh, thanks. Thanks are nice. Great. I hope it was valuable and I didn't waste your time. Oops, I don't know where you guys went. And I didn't waste your time, and you got something out of it. And any questions? My email is on the front slide. Don't hesitate to reach out and say hi to me when you come and drop patients off.
Yeah, Dr. Cohen, we have a pretty robust follow-up round robin here. So if you are open to it, if we bring pediatric trauma to the general and we drop you a line, could you provide the crew's feedback on how the patient made out? And
Yeah.
that would be great because
Yeah, of course we do that. We do that all the time. I also am one of the Med-Flight Associate Medical Directors, so we provide feedback to them all the time about patients that come in, and happy to do it for your team as well.
Cool, great. Thank you very much.
All right, Doctor, thank you. Everybody else just want to stay on for 1 minute before you sign off. We'll just go over what you have to do for the rest of your NCCR. That'd be great. Again,
Bye,
thank you
all.
very much, Dr. Cohen.
Bye-bye.
All right, the rest of this week is podcasts on the EMS learning management system. It's all set up. If you're coming in for practical next week, it's 5 o'clock at Rivermore Street. Tuesday for the people who have signed up for Tuesday. Thursday for the other group. This week, like I said, is podcast. Next week is foam frat. They are both open and available if you would like to do them ahead of time. That is fine with me. I will keep track of your podcasts and your quizzes and your foam frat submissions. Payroll for today has been entered, so check it. Make sure it's what you want, what you need. If there's any questions, please reach out to me. Email, phone, or text works. I'll be available during business hours for the rest of the week if you need it. Any questions for me on that, for anybody? Great. I can help you log in and get everything else you need. And thank you all for doing your ACLS and PALs. Those were also entered last week, unless you got them into me late, then they were entered for yesterday.
Yeah,
Thanks,
yeah.
everybody. Deputy?
Guys, a couple of people sent me some emails. No, that's all right. I'm getting, I was gonna say, please follow up on your text that you just sent me because I don't understand what you mean, but you just sent it, so thanks. All right, everyone, we'll see you on Tuesday or tomorrow, depending.
Thank you.
Thanks, guys.
Thanks. Thank you, guys.